All right, we'll get started. Good afternoon, everyone. Welcome to Research and Innovation Conference. My name is Michael Ho. I'm the Vice Chair for Quality for the Department of Medicine. Today, we have two great talks for you. To start us off, Dr. Laura Peters will start us off this afternoon. She is an assistant professor in the Division of Cardiology. And today she's going to talk about hope for the best, plan for the worst, integration of advanced care planning in ambulatory specialty clinics. So with that, Laura, I'll let you get started.
Great. Thank you so much, Dr. Ho. I'd also like to thank the Department of Medicine Research and Innovation Conference for this opportunity today to speak with you and present the quality improvement project that I've been working on. Today, I'm going to share with you how two ambulatory specialty clinics have been working to integrate advanced care planning in the care of the patients who are seen in these clinics. Oh, hold on. There we go. I have no conflicts of interest to disclose. I do want to note, though, that this topic is personal for me. My mom was diagnosed with terminal cancer at the age of 54. The impact of advanced care planning during those difficult months were crucial to allowing my mom to experience the end-of-life process in ways that honored who she was and what she valued. Advanced care planning assisted my family in being able to listen to my mom, accept the choices she made, and provide her best care possible. Through advanced care planning, my mom was able to voice her desire to die in her home, surrounded by those who loved her, and it allowed us caring for her to provide the care she desired. Despite the positive ways that advanced care planning can improve care for patients and their social support, advanced care planning is still underutilized. 2 years into the COVID pandemic, the critical importance of advanced care planning has been further highlighted. If any of you have experienced end-of-life discussions with caregivers who are unclear about the patient wishes, you can attest to the challenging nature of all of the opinions. Advanced care planning seeks to align medical care with patient goals of care, focusing medical interventions on those the patient wishes while minimizing interventions that are incongruent with patient wishes. Completing advanced care planning then provides guidance for caregivers when they are in the difficult position of having to make decisions on behalf of the patient. Colorado is an all-interested party state, which means that any interested party can participate in end-of-life decisions for a patient if that patient has not specifically designated a decision maker. If patients want to control who makes decisions on their behalf, they must appoint a specific party on an advanced care planning document, such as a medical durable power of attorney form. UC Health noted the importance of advanced care planning in the early months of the pandemic. They worked to create committees and initiatives through clinicians across the system to increase patient awareness of and access to advanced care planning. One of the specific initiatives was to increase scanned medical durable power of attorney forms by 4% by the end of 2021. Oh, there we go. The quality improvement project I'm presenting today, as I said earlier, is the integration of advanced care planning into two specialty ambulatory clinics, the heart transplant clinic and the COPD clinic. These clinics were chosen because they follow patients with chronic illnesses who are high risk for deterioration over time. Specific aims of the project included increasing MDPOA completion and uploading the MDPOAs into the electronic medical record, increasing the number of advanced care planning conversations that happened in those clinics, as well as documenting these clinics in the Advanced Care Planning Navigator in Epic, billing for advanced care planning conversations, and then increasing advanced care planning referrals to social work. In December 2020, the heart transplant clinic had 36% of all patients with a scanned MDPOA form. We developed a My Health Connection message, linked the eMDPOA form to this message, and sent it out to all heart transplant patients who had an MDPOA or who had a My Health account. By May 2021, 41% of the heart transplant patients had completed an MDPOA. We continued our work through additional interventions. So we began by providing advanced care planning education to clinicians. I apologize, my slides are, there we go. We also developed an MDPOA completion process, which I will describe in detail shortly. We added an advanced care planning reminder to the RN check-in form that they were already using. And then we also added an MDPOA completion column to our clinic schedules. And you can see a little snapshot of what it looks like up here. But this provides an easy visualization of who was in clinic that needed to have an MDPOA form completed that day. The Heart Transplant Clinic decided on a multi-prong approach to completing MDPOAs with our patients. So we started with a patient encounter when they were in the evaluation phase of heart transplant. The social worker met with the patient for the heart transplant evaluation, and during that visit, they would verify if the patient had an MDPOA. If they did not, the social worker worked with the patient to complete the MDPOA. Then, prior to listing, the pre-transplant coordinator would verify that the MDPOA is completed. For patients who already were transplanted, we had two different processes for completion based on patient encounters. During the clinic prep that the RN completes, the nurse checks the MDPOA status. If the patient does not have an MDPOA, they send a My Health Connection message linking the eMDPOA form to the message prior to clinic for the patient to complete. For patients who present to clinic without an MDPOA, we then completed this in clinic. We found that the most successful way to complete this is with paper MDPOA forms, so we added MDPOA forms to our clinic. The nurse checks in the patient, and if the patient does not have an MDPOA, as I showed on the previous slide with the red X, the MDPOA form is brought into the clinic visit. The nurse then provides the paper, the patient fills it out while they're waiting for the provider. And then when the provider comes in the room, they can answer any questions the patient may have, and they verify the decision maker the patient has identified. This is the My Health Connection MDPOA message that we developed. We made this a dot phrase for easy access. This is used for the My Health Connection message as well as on the after visit summary if patients do not have an MDPOA completed. We also developed advanced care planning resources for patients who requested additional information. This is also a dot phrase, and this is able to be added to the after visit summary in different ways, depending on which resource was most appropriate for the patient. This table highlights MDPOA completion charted every month of 2021 in the Heart Transplant Clinic. So you can see we sent our My Health Connection message in December, and you can see in January a small increase in MDPOA completion. We then completed education and developed our processes through the spring, and in July of 2021, we successfully implemented the processes just described. And you can see over the course of the next several months, we have a steady climb in MDPOA completion. So looking at fiscal year 2021, from December 2020, we had 36% of all heart transplant patients with an MDPOA completed. And 12 months later, we increased this to 58%. The COPD clinic created a similar process. They also have an RN that does pre-clinic work. So they call the patient for a clinic visit reminder. During this phone call, they will make sure the patient has an MDPOA on file. If not, they will notify the patient they don't have this. They can send a My Health Connection message with a dot phrase and link the eMDPOA form to that, and then ask the patient to complete that prior to clinic. And then again, they had the encounter if the patient presents to clinic without an MDPOA. They will then check in the patient and provide the paper form or explain how to complete the form on the My Health Connection app. The patient will do that while waiting for the provider, and then the provider again can answer any questions or help them fill out the form should the patient need that. So preliminary data over the last few months. In July 2021, 32% of all patients seen in this clinic had completed their MDPOA. And by December 2021, 36% overall. And I like this chart because it kind of helps show a different visualization. You can see sort of the education and development that happened in the summer with this clinic. And we did some pilot months, July and August, and made some tweaks to the process. And then we really implemented it in earnest starting in September. And since then, they've had a nice steady increase of MDPOA completion. Again, as I've highlighted, I think it depends on the clinic and the type of patients that you have, but both clinics found that having the MDPOA completed in clinic was the most successful way to get this completed. The heart transplant clinic, it's interesting. Most patients do use My Health Connection, and they prefer that actually for medication, dose changes, communication about therapy plans, questions to their coordinators. But for some reason, using My Health Connection to complete the MDPOA just did not take off near as well as actually just having it done in the clinic visit. This past summer, UC Health also created an initiative to have patient-entered wishes be turned on in Epic and through My Health Connection. So it went live this past July, and now the My Health Connection website and app has a section under advanced care planning that patients can type in their specific wishes while they're at home or waiting for a clinic or whatever. They don't need to have it done in an advanced care planning conversation. And you can see the questionnaire here. It talks about what makes life worth living for the patient. It offers statements for how the patient feels at that moment about their current health, and then offers an area to explain why they chose that statement. And then it also asks, if you were sick and close to the end of your life, would you make the same choice, and why or why not? When patients complete these, it is then filed into their electronic medical record in the Advanced Care Planning Navigator. When the patient presents to a UC Health clinic, a passive BPA will then display in the storyboard for the clinician that is seeing that patient. For most clinics, the BPA can be addressed through two ways: to either mark as review and discuss the patient-entered wishes in that visit, or to defer the discussion and then provide a reason why that was deferred that day. The system asked for some pilot clinics to do a referral to social work as a third option. The heart transplant and the COPD clinics were selected as pilot clinics for this social work referral. And what this does is adds a third option to that BPA. So you can either defer conversation, you can have a conversation in that clinic visit, or you can send a referral to either the ambulatory social work pool for the COPD clinic or to the heart transplant social work pool for the heart transplant clinic. This was developed in the fall, and then go live was this past December. So this is what it looks like. On the left, you can see there's this is a fake patient. You can see the storyboard BPA. It says that the patient has wishes to review. And then when you click on it, again, you can, these clinics will have the option to order a social work referral. And this is what the referral looks like. So you can click advanced care planning. It will automatically say that that's a patient wishes discussion, but then you do have the opportunity to add further comments should there be something specific that the patient is wishing when you see them in clinic that day. Some future steps that we hope to complete moving forward. We hope to develop a strategy to identify high-risk patients for advanced care planning conversations. And then through that identification, offer an advanced care planning clinic visit to those patients. So currently we plan to offer this as a tagged onto an upcoming clinic visit, or a virtual visit, or an extra visit should the patient be willing to come to to campus again. The benefit of implementing and identifying them before just seeing them in clinic is that we can also then invite social support to attend. So we can say, you're identified, you have some risk factors, you were in the hospital 3 times in the last 6 months, or you have a terminal illness, a new diagnosis. We'd like to have an advanced care planning conversation. Is that something you're interested in? And then we can have them invite their social support so that that can really be a discussion with everybody on that patient's team. We also hope to bill then for these advanced care planning conversations. So we're going to do education for clinicians around documenting in the advanced care planning navigator, and then also how to bill. And then lastly, we hope to do an economic analysis of our advanced care planning interventions in partnership with Accords. I'd like to thank you again for this opportunity to present my project, and I'd love to answer any questions that anyone might have.
Great, thanks, Laura. It looks like we do have a question. Yes, does anyone in the clinic support or assist the patient in choosing the healthcare agent? What is done to encourage support the patient in informing the designated healthcare agent and having conversations with the agent and family about the end-of-life wishes and values? Maybe do you want to answer those first, and then there's a follow-up to that?
Yes. So in terms of assisting the patient in choosing a healthcare agent, that is something that the nurses, so in the heart transplant clinic, the RNs are their transplant coordinator, and patients develop a close relationship with them over time. Most patients, if they have a question, they will start with the transplant coordinator. Who do you think I should ask? Or do you have any advice on who would be a decision maker? Or often that would be the provider. I honestly have to say most patients don't hesitate. I've had 2 patients that I can think of that have been like, I'm not sure who to ask. And actually, a sad story, but the patient was in clinic. She said, I don't want to choose anybody. And I said, it's worthwhile to think about this. She's like, I'll think about it some other day. And I said, what happens if you get in a car accident today and you need somebody to make your decisions for you? And so she thankfully was like, I think this would be the best person, the most logical. This is who I want. She filled out the form. And actually a week later, she was admitted, unable to make medical decisions, and ended up passing away. And so there's some of those really tragic stories kind of going to why we are all at high risk for dying. Why not offer it? I think that is something that we are really trying to do in these 2 clinics, is having at least the beginning of advanced care planning conversations through designating a decision maker for every patient that enters these clinic visits.
Great, thank you. And then next question, what have you found to be the biggest barrier to ACP completion?
Yeah, should I answer the one? It looks like it says, since we're all at high risk for dying, why not offer ACP visit for all adult patients? Realistically, time. So these conversations, if we were going to have them with every single patient in the UC Health system, would require hiring a whole bunch of new staff and stuff, just because of the amount of work that they can be. Not that they're not important. I think the reality is, though, that I don't think we're fully staffed to be able to do that across the system. I do think there's a ton of initiatives, though, going out, and that's partly why the EPIC turn-on was for patient-entered wishes. So trying to get patients to think about this outside of a clinic visit, and then being able to designate specific clinic visits so that there is time, because in my clinic, I have 30-minute visits, and that is, my time is basically used up in that 30 minutes with heart transplant care. So to add a 15 to 30-minute advanced care planning conversation on top of that, and I will say most are over 15 minutes, you're adding a ton of extra time to a clinic that may not be able to staff that. Okay, sorry. And then biggest barrier to advanced care planning completion. I think it would be maybe the lack of motivation. Maybe I think people just don't think about dying that often. maybe a little bit more with COVID. But a lot of people just don't see the rush to completing it. I think they're like, yeah, I'll make a decision maker, but they, are at the grocery store when they get the My Health Connection message and they just move on. And so even just completing it on the phone, for whatever reason, we sent a message, they always read them and they just would never take the extra 5 minutes to do them. I don't know if it's just a lack of urgency. That would be, I think, my biggest barrier. And looks like what patients who have no relatives or close friends who will serve. Again, I have had a couple patients who have been in that situation, and I've not had anybody that cannot come up with a name of somebody that they would have, that they say you can call them and ask them to make decisions for me. I think if they don't have it, then they wouldn't complete it, I guess. And again, we're not forcing anybody to complete these. It's really just a matter of if the patient wants to be able to be in control of who would make their decisions.
Great. And then I think the last one is the ACP Navigator currently accessible to all clinics?
Yeah, that's a great question. It is accessible. It's the easiest way to access it is through the storyboard, and I'd be happy to help anybody who is interested in learning more about that, kind of have a little bit of education and show them where to find it. But yeah, it is. The nice thing too is there's also, and I can share some of this as well, there is an advanced care planning dot phrase that you can pull into your note. And then if you document in the advanced care planning navigator, you can pull it directly into your note to show that you had those conversations. The nice thing with the advanced care planning navigator is that if you document there, all of the patient advanced care planning stuff is there. You don't have to dig through all of the different notes with palliative care, or a lot of times people have these conversations multiple times. So the advanced care planning navigator is continually updated with the most recent information. And so that's nice for people when you're having end of life discussions to be able to find it easily in the chart.
Great. And I had a question. So Laura, I mean, you showed increases in in completion rates, after your intervention. Were there differences in the way the clinics implemented it? And, are those generalizable as you think about implementing it in more clinics, presumably in the future?
Yeah, both clinics tried a few different strategies. One strategy, as I said, was sending My Health Connection message to the patient prior to them coming to clinic. I know of one clinic that actually sent out a message to schedule the COVID vaccine back when they were starting to be rolled out. And with that message, they actually linked the EMDPOA, and there was a huge response. So if there's some urgent new thing, that tends to have a bigger draw to completion than just sending out a one-time message. But I will say both clinics that did the implementation, and then I just started working with pulmonary rehab actually, and they're finding the same thing, is completing that MDPOA in person with the patient when they present to the clinic. That has the highest yield for the least amount of time. And again, I've done it both ways with patients, shown them how on their phone to complete the EMDPOA, but most times if I just bring it in and ask them fill these things out on the form, it's done in under 2 minutes. And that seems to have the highest yield.
I mean, I think, at some point as you're finishing up your evaluation, I think it'd be helpful to understand, since you talked about all these initiatives that UC Health is also undertaking, and then there's your intervention, it seems like it'd be nice to understand what's the impact of your intervention, in relation to the background rate, because it's probably also increasing a little bit because of the various initiatives that are ongoing, and you want to be able to say how much more your intervention added to that background rate.
Yeah, that's a really good point.
Great. Well, thank you so much for such a great presentation and a great conversation. Thanks again for doing the presentation, Laura. So our next speaker is Mark Gritz. He's an associate professor in the Division of Healthcare Policy and Research, and he's the current division head of that division. Today, Mark is going to talk about 1 year off mute assessment of first Colorado COVID-related telemedicine policy changes. Thanks again, Mark, for doing the presentation today.
Great, thank you, Mike, and thanks everyone for the opportunity to talk about this work that we just completed a couple months ago. I want to start off with this work was funded by the state Office of Planning and Budget, and it was done in conjunction with the Department of Healthcare Policy and Financing, which is sure many of you or most of you know is our state Medicaid agency. While both, OSPB, Office of State Planning and Budget, and HCPF were involved in this, obviously any statements and conclusions are those of the authors. And this was funded through the Farley Health Policy Center that is here on campus. Okay, let me see if I can get my slides to, there we go. So the state Medicaid agency introduced a number of policy changes in response to the public health emergency, and they were introduced in March of 2020. And the key policy changes that were made was they opened up telemedicine for a much broader set of services. They provided payment parity, so a telemedicine visit is paid at the exact same rate as an in-person visit. They expanded telemedicine to include telephone only instead of, traditionally it was a audio video type of an engagement with a patient, and it included just telephone only as well as chat only. They also opened up reimbursement for telemedicine services for federally qualified health centers, rural health centers, and Indian health services providers. And they also expanded the services to include home health, hospice, therapies, and pediatric behavioral therapy. And then in November of 2020, they expanded it to include well child checks. Those are not included in our analysis as a telemedicine eligible service, partly because they were instituted several months later, and we wanted to look at a full year of experiences after the policy changes. So our analysis is not going to look at well child check visits. There were really three things that the State Planning and Budget Office was interested in. One was, did these changes in policy improve access to care during the pandemic? And did it alleviate or exacerbate disparities that were already existing in access to care, particularly around racial ethnic groups and medically complex Health First Colorado members, which is our state Medicaid program. Second, they were interested in the quality of the telemedicine visits relative to in-person visits. And third, they wanted to know, did this expansion of telemedicine services increase costs for the Medicaid program here in Colorado? To address that first question about improved access and in particular, did it alleviate or exacerbate existing disparities? We worked with Denver Health, which is a federally qualified health center here in Denver, to look at two aspects. One is, did telemedicine change no-show rates for scheduled appointments? And second, did changes in those no-show rates, did they differ by racial, ethnic, and medically complex patients? And so we were looking at no-show rates for in-person and telemedicine scheduled appointments, looking at 4 areas of care. One is primary care services. The second are embedded behavioral health services that are integrated into a primary care setting, specialty care services, and specialty behavioral health services. And all of these are in an outpatient ambulatory setting. As I mentioned, we were using data from Denver Health. They very much serve a majority of their patients are Medicaid, so 58% of their scheduled visits are for Medicaid members. Denver Health worked with us to provide information on the number of appointment slots in each of those 4 care settings that I just mentioned, scheduled appointments, and then the status of those scheduled appointments, where they were either a no-show, completed, or a canceled visit. They also provided us with patient data on payer, sex, age, race, ethnicity, and then to get at medical complexity, they provided us with information on a risk tier program that they implemented several years ago that categorizes patients into 4 risk tiers, where the 4th risk tier is the most likely to have medical complexities. They're at a high risk of having high cost as well. They provided us with 36 months of data, 2 years before the declaration of the public health emergency and 1 year after. So we have data from March 15, 2018 through March 15, 2021, the 4 categories of care. And Denver Health in particular started with almost audio only telemedicine appointments. They've gradually been able to increase that to include audio video telemedicine appointments. However, for this analysis, we combined the audio video and audio only because they had such a small number, even over a year later, that were audio video. So the main approach that we took here was to assess differences between in-person and telemedicine no-show rates in a pre-period, defined as the 2 years before the public health emergency, and a post-period, the 1 year after. We looked at no-show rates in each of the 4 categories, and we included patient characteristics of race, ethnicity, age, sex, and health tier risk. Just to quickly talk about some of the results, telemedicine did reduce no-show rates, and it also reduced racial ethnic disparities in no-show rates for primary care and integrated behavioral health. So these 2 graphs, the one on the left presents the no-show rates for primary care appointments pre and post, and the one on the right presents the no-show rates for scheduled integrated behavioral health appointments, again, in a pre-period and the post-period. As I mentioned, there were very, very few telemedicine visits in the pre-period, so we only have no-show rates for in-person care in the pre-period. The black bars are for Hispanic patients, The blue are non-Hispanic white, the gray are non-Hispanic black, and the gold bars are non-Hispanic multiple or other race categories. And one of the key things that we found is that you'll notice there were slight reductions in no-show rates overall for in-person visits, but the no-show rates for telemedicine visits were substantially lower. Instead of having a no-show rate of, 26% for non-Hispanic Black patients, it dropped almost in half to about 13%. And similar drops for the other race ethnicity categories. But the biggest point is really, the reduction in the differences between no-show rates for telemedicine appointments across these racial ethnic categories. For the in-person rates, even during the pandemic, there were 6 to 7 percentage point differences for non-Hispanic Black patients for in-person, but that drops to about 2 to 3% for telemedicine visits in the post period. For the primary care visits, there was a slight less of a reduction for the integrated behavioral health, but again, it still reduced the disparities across these race ethnicity categories. We found similar results across the risk tiers as well, in that telemedicine reduced the disparities across risk tiers for the more medically complex patients. The findings are in our report, but not reported here. Similarly, for specialty care, there was a reduction in no-show rates. For physical health specialty care, and a little bit less so for specialty behavioral health. But again, the disparities, particularly for specialty care, were reduced. So in answering that first question, it does appear that these policy changes definitely improved access to care through a reduction in no-show rates, as well as it alleviated some of the disparities that were present before the pandemic and are still present there for in-person visits. We also looked at the second issues around quality and costs related to these telemedicine policy visits. And to address quality issues, we just have claims data available to us. So it was, we had to find some proxy measures for quality. And so what we decided to look at were differences in the likelihood of a subsequent primary care visit and ED visit following a initial index primary care visit, either in person or via telemedicine. So we're really comparing in-person to telemedicine visits after the pandemic and these policy changes, looking at, are those that follow a telemedicine visit more likely to have a subsequent primary care or emergency department visit? We had data on about 1.25 million Health First members that were covered between March of 2018 through August of 2021. The additional months beyond March of 2021 are necessary in the claims data to account for claims run out, particularly for emergency department visits, as those claims are not as timely as primary care visits. We excluded months in which members were in a managed care program or Medicare and Medicaid eligible because the claims data that we have are less complete for those populations. We identified just under 9 million index primary care visits over that 3-year period. The vast majority, about 8.2 million, were in person, and about 600,000 were telemedicine visits. We identified an index primary care visit using the CPT codes that were authorized as a payment as a telemedicine visit, excluding those well-child visits, as I mentioned. And the claims data also did not distinguish between audiovisual or audio-only modes, so those are combined. We examined the subsequent ED and primary care visits. We separated them into those that were for a same or similar diagnosis versus a different diagnosis as the index visit, using the clinical classification software that HRQ provides using ICD-10 codes. We applied time to event statistical models, looking at cumulative incidence analyses, as well as a Cox proportional hazard competing risk model. As I said, comparing in-person to telemedicine. The Cox models accounted for patient characteristics, including race, ethnicity, age at the index visit, sex, health status, or medical complexity at the index visit, residence in an urban or suburban or rural area, and then the primary diagnosis at the index visit. We estimated separate models for children, adults, and individuals with disabilities, as well as for all members. We also ended up dividing the post-pandemic, or the actual during the pandemic period, into 3 periods based off of kind of the waves in COVID that we experienced. So we had an initial period that went from March of 2020 through June, and then looked at July through November, which was kind of a lull, and then December through March of 2020 through March of 2021, as there was a resurgence of COVID during that period. This graph shows the cumulative incidence of a primary care visit following a in-person and telemedicine index visit, where we're looking at the first day following an index visit, 7 days later, and 10 days later. And the graph on the left is showing the cumulative incidence of subsequent primary care visit. The one on the right is cumulative incidence of ED visits. As you can see, the telemedicine does result in higher cumulative incidence of subsequent ED and primary care visits. So the gray bar is an in-person with the same diagnosis group. Gold are telemedicine with the same. The black are in-person with different, and the blue is a telemedicine with different. And so you can see, even though the rates are pretty low for both ED visits, by the time you get to day 10 for a telemedicine visit, they're showing up at a subsequent primary care visit almost 5 percentage points more likely after 10 days for a different diagnosis at that subsequent visit than they had at the primary or index visit. And that was results for children. So basically, telemedicine index visits did not appear as effective for children. However, for adults, the results differed, and it does appear that telemedicine visits are as effective for adults as opposed to children. And these graphs just show those same things for the adult population. We also looked at, as I mentioned, the Cox proportional hazard models. Again, for children, there were significant differences in the relative odds and the difference in predicted cumulative incidence at 7 days, whereas for adults, they're, again, even through the adjusted model, there is not a difference between telemedicine and in-person for adults, but there are for children. So it confirmed that cumulative incidence graphs that we just went through. Key policy implications for this, our recommendation is to maintain parity for audio-only telemedicine. It expands access to patients with limited access to reliable internet and smartphones. Access is not as reliant on tech literacy with the audio only, and it addresses disparities across race, ethnicity, and medical complexity, as well as it's critically important for FQHCs, regional health, rural health centers, and Indian health services. And even though telemedicine PC visits are likely to increase overall utilization of primary care and ED visits for children, the increased access that they provided, we believe more than offsets that potential additional cost from higher utilization. Just to acknowledge all of the collaborators on this. So at the Farley Center, Mushing Alicia He, Emma Gilchrist, Stephanie Gold, Susan Matthew, Carter Civic, and Jake Thomas. Denver Health, Rachel Everhart, and Doug Robinson helped provide us data, and also listed the staff at HCPUF and the Governor's Office of State Planning and Budget. And that's it. So happy to address any questions.
Great, thanks, Mark. Yeah, if you,
there we go.
If you have any questions, please enter it into the chat. Mark, did you guys look at which types of patients were more likely to opt for telemedicine visits versus in-person over this period of time?
You mean in terms of just characterizing the patient characteristics?
Yeah.
We did. I don't recall those results right off the top of my head, but it seemed to be a pretty representative set that were using telemedicine. It varied a little bit over time as the pandemic sort of waxed and waned. But I don't have those directly right off the top of my head.
Okay, yeah, and I was just wondering, were there disparities or different, more importantly, differences in those that were more likely to opt for telehealth versus those more likely to present in person?
My recollection was not anything that was really stood out.
Yeah, okay. And then in terms of quality, other than repeat visits, visits to the PCP and ER visits, did you look at other quality measures as far as, quality of care provided during telehealth visits versus in person?
No, we did not. All we had was claims data. And, once we got, that was, and if someone has other ideas of using claims data to try to get at the effectiveness or quality, love to hear it, because that was the best one we could come up with as a measure of effectiveness
Yeah.
or quality. You know,
No.
we had no clinical measures at all, right? It's claims data. So
Yeah. I guess although if you're using Denver Health patients, there is the possibility of linking it to Denver Health clinical records.
in principle, yes. So the claims analysis was statewide, not just Denver Health. So it was all 1.2 million Medicaid members in the state. Limiting it down would have significantly reduced the number of telemedicine visits we had. So we were really trying to look statewide and capture as big of a swath of the population as possible.
Sure. And then it sounds like there's going to be continuing reimbursement for telehealth visits.
I would hope so.
Yeah.
Obviously, that's part of the budget process that's going on now in the legislature, is to make sure that, and that's really what this study was done for, was to help inform that. So
yeah,
I hope, and just my personal opinion is, yes, it should maintain parity for audio only, in particular, telemedicine visits.
I mean, it would be interesting, and I don't know if then you would need to make coding changes. It would be important to understand also the difference between phone versus video visits, because I suspect the access to the technology will create some barriers.
Yes, and I think that was Denver Health's experience anecdotally, that the audio only was absolutely critical. I mean, anecdotally, even talking to some of our own providers, medicine providers, even if they started with an audio video, there was quite frequently something happened and they switched to a telephone only.
Yeah.
So it provides a valuable option for patients that I think does improve access and reduce disparities. But yes, right now, coding does not distinguish between audio only or audio video. And it would take a coding change, which would take a lot more policy changes, I think.
Yeah. Okay, great. Well, I don't see any questions. So with that, I want to thank you, Mark, and thank you, Laura, for really two interesting talks. And I hope you guys have a great rest of your day. Thank you so much.
Great, thanks. Bye.
Bye-bye.